We will be talking about obsessive-compulsive disorder with Karen Rusa as our subject in the final part. Part 5. Theoretical perspectives and treatment implications. Here we will go through some theoretical perspectives and treatment implications. According to traditional psychoanalytic theory, compulsive symptoms are the product of the ego's unconscious attempt to fend off anxiety associated with hostile impulses. Freud argued that compulsive patients had experienced overly harsh toilet training and were therefore fixated in the anal sadistic stage of development. Such individuals presumably suffer serious conflict over the expression of anger. Because these feelings are dangerous, or unacceptable to the ego, the anticipation of their expression is seen as anxiety-provoking. This anxiety is dealt with primarily through the defense mechanism known as reaction formation, in which the original impulse, anger, is transformed into its antithesis, love or over-solicitude. This conceptual approach is not incompatible with Karen's situation. Her principal symptoms were compulsive rituals that were intended to protect her children from harm. But her feelings about her children were, in fact, ambivalent. It would not be unreasonable to assume that she was most often very angry with them, perhaps to the point that she might have considered doing them physical harm. Of course, this impulse would be anxiety-provoking to the ego, which would convert it to its opposite form. Thus, instead of injuring the children, she would spend a good deal of her time every day performing irrational responses aimed at protecting them. Most contemporary therapists agree that people with OCD have trouble expressing anger. Some recognition was given to these considerations in the treatment that was employed. Karen's anger and frustration were identified as central features of her adjustment problems, but the therapeutic procedures went beyond the goal of insight-oriented treatment. Karen's recognition of her anger and hostility was not sufficient to effect change. Specific training procedures were used to help her develop more adaptive responses. Learning theorists would view Karen's problems in a distinctly different fashion. Within this general model, two factors would be given primary consideration. Both involve the principle of negative reinforcement, which states that the probability of a response is increased if it leads to the termination of an aversive stimulus. Consider, for example, the net effect of Karen's rituals. Their performance ensured that she would be away from her home for extended periods of time. If she went to her neighbor's house for coffee, she would be gone for at least 2 hours before she could consume enough cups and smoke enough cigarettes to satisfy the rituals. Grocery shopping, which she did by herself, had also turned into a long, complicated process. Given that being at home with her family was mostly an aversive experience for Karen, her rituals might be seen as an operant response that was being maintained by negative reinforcement. A behavioral clinician would be most likely to point to the anxiety reduction associated with the performance of the rituals. Whenever Karen was engaged in an activity that reminded her of numbers and, consequently, her children, she became anxious. She was able to neutralize this anxiety temporarily by counting the appropriate number of boxes and so on. This ritual was therefore reinforced and maintained by the reduction of anxiety. This notion is similar to the psychoanalytic view in that the symptom is produced as a means of reducing tension. The two theories differ in that the behavioral view does not see her anxiety as being directly attributable to the unconscious urge to harm her children, nor does the behavioral view hold that the anxiety reduction is mediated by an unconsciously activated defense mechanism. Some elements of the behavioral view were incorporated into the treatment procedure followed with Karen. In particular, by teaching her to be more assertive and to manage her children more effectively, the therapist was able to make her home life less aversive. She now experienced more pleasurable interactions with her children and her husband, and one important source of negative reinforcement for her rituals was removed. Unfortunately, this view of human behavior is fairly limited. In particular, it does not account for the importance of cognitive events. By focusing exclusively on environmental events, behaviorists may ignore important factors associated with the client's perceptions, beliefs, and attitudes. These variables also seem to play an important role in Karen's problem. Cognitive theories regarding the etiology of OCD emphasize the importance of excessive feelings of responsibility and guilt. This viewpoint begins with the recognition that most normal people experience intrusive thoughts from time to time, especially when they have been exposed to stress or negative mood states. Most intrusive thoughts do not become persistent or troublesome because people do not assign special meaning to them. According to the cognitive model, obsessions may develop if people interpret their intrusive thoughts as proof that they will be responsible for harm to themselves or others if they do not do something immediately to correct the thought. People most likely to develop OCD may be those who a. learned a broad sense of responsibility and a high level of conscientiousness at an early age. B. were exposed to rigid and extreme codes of conduct and duty, for example, have learned that some thoughts are particularly dangerous or unacceptable. C. experienced a critical incident in which their action, or inaction, or their thoughts seemed to be connected to a harmful incident that affected them or someone else. Alarmed by the intrusive appearance of forbidden thoughts, the person may struggle to avoid them, but cognitive events are difficult to control. In fact, active attempts at thought suppression often backfire and increase the severity of the problem. This vicious negative feedback loop magnifies feelings of helplessness and loss of control and also serves to focus attention on the content of unwanted thoughts. The person's anxiety level continues to escalate, and compulsive rituals are employed in an attempt to regain control over mental events as well as life experiences. The relevance of this perspective to Karen's case is clear. She had experienced frequent intrusive thoughts related to her children's safety, and she did believe that a failure to act in response to these thoughts would result in harm coming to her children. As a child, Karen had been taught that certain thoughts and ideas were bad and that strict observation of the rituals of the church would guarantee her salvation and prevent harm from coming to her. These rituals became the primary means for controlling her fate and ensuring her safety. As an adult, Karen found herself stripped of these control mechanisms. The church now maintained that salvation, or the protection of one's soul, depended more on faith than on the performance of specific overt behaviors. When Karen experienced the critical incident in which her friend's infant daughter was injured, and she began to experience intrusive thoughts about harming herself, she turned to the use of private prayers in an attempt to protect herself. In some ways, Karen's subsequent development of counting rituals represented a substitute for the formal religious practices she had learned as a child. She admitted that they were irrational and probably unnecessary, but they did reduce her immediate anxiety in much the same way that going to church had left her with a comforting feeling as a child. Karen's treatment addressed various cognitive factors, including efforts to improve her sense of self-control. Treatment was aimed initially at reducing the level of stress, improving Karen's mood, and giving her alternative means of controlling her environment, such as assertion training and instruction in parenting skills. Considering her deeply ingrained religious beliefs, it was also judged necessary to help her re-establish contact with the church. After these procedures had achieved some modest success, it was possible to attack the counting rituals directly through the use of exposure and response prevention. A cognitive therapist would view the process of exposure and response prevention as a kind of behavioral experiment in which the person is given an opportunity to disconfirm exaggerated beliefs about responsibility, meaning, if I do not count the cereal boxes, something bad will happen to my children. An extensive body of evidence indicates that behavior therapy is effective in treating compulsive disorders. The most useful procedure seems to be in vivo, aka, in the natural environment, exposure coupled with response prevention, ERP. Studies that have compared ERP with control treatments, such as applied relaxation, have found that patients who receive ERP, typically between 15 and 20 sessions, are more likely to experience substantial improvement. Some patients, of course, refuse to enter or drop out of behavioral treatment, perhaps because it is initially anxiety-provoking. Motivational interviewing can be used as an additional procedure to increase adherence to behavioral treatment methods. Among those who do complete ERP, approximately 80% have been classified as improved, and most OCD patients maintain these improvements several months after the end of treatment. Cognitive therapy is another psychological approach to the treatment of OCD. It is concerned primarily with the meanings that a person assigns to intrusive thoughts, images, and impulses. Symptoms of OCD are presumably more likely to occur if the person interprets the thoughts as an unquestionable sign that he or she is responsible for either causing or preventing harm that might come to oneself or other people. Cognitive therapy helps the person develop and use different interpretations of intrusive thoughts that do not require or motivate the person to continue to engage in compulsive rituals that are clearly ineffective and self-defeating. Treatment outcome studies report that this type of cognitive therapy can be an effective form of treatment for people with OCD. Medication is also beneficial for many patients. Clomipramine, anafranil, has relatively specific effects in reducing OCD symptoms. Its therapeutic effects cannot be attributed solely to a reduction in comorbid depressive symptoms. Sustained improvement depends on continued use of the drug. Most patients experience a return of OCD symptoms within 4 weeks after they stop taking the medication. The newer generation of antidepressant drugs known as selective serotonin reuptake inhibitors, SSRIs, including fluoxetine, Prozac, fluvoxamine, Luvox, and sertraline, Zoloft, has also been used with OCD patients. Controlled studies indicate that these drugs are also effective in the treatment of OCD. The SSRIs are often preferred to other forms of medication because they have fewer side effects. Several issues will need to be addressed in future studies of treatment outcome. Relatively few direct comparisons of medication and ERP have been reported. It is not clear whether the combination of pharmacological and behavioral treatments is more effective than either one by itself. Perhaps more important, it is not currently possible to predict whether a particular patient will respond better to ERP or to medication. In actual clinical practice, medication is often used in combination with behavioral therapy for the treatment of OCD. When both psychotherapy and medication fail, one other form of treatment may be considered, neurosurgery, which refers to techniques in which neural pathways in the brain are surgically altered in an effort to change the person's behavior. Although neurosurgery was originally intended to be used with psychotic patients, clinical research indicates that it may be most effective with obsessive-compulsive disorder. One longitudinal study described 26 patients who had received neurosurgery after failing to respond to all other forms of treatment. In comparison to similar OCD patients who had not received surgery, 10 of the 26 patients were obviously improved several years after the procedure was performed, 6 others showed mild improvement, 6 were unchanged, and 4 had gotten worse. Because the duration of illness prior to surgery was several years for all the patients in this study, the reported rates of improvement are probably not due to placebo effects or spontaneous remission. These results cannot be ignored, but they should also be interpreted with considerable caution. First, it is virtually impossible to conduct a double-blind evaluation of neurosurgery. Second, surgical procedures have varied widely across studies, thus making general statements about neurosurgery questionable. Third, and perhaps most important, neurosurgery may produce general changes in the patient's intellectual and emotional capacities. These changes remain unpredictable and poorly understood. Thus, most investigators agree that such radical procedures should be considered only when the patient's symptoms are chronic and severely disturbing and when other treatment programs have already been unsuccessful.
This is the end of our OCD Read With Me series. Check out the previous chapters in the series. In the first chapter, we introduced the topic and subject. In the second chapter, we went over the patient's social history. In the third one, we talked about the conceptualization and treatment of the disease. And in the fourth one, we discussed the case in details.